Are acting kind of nuts. If there are any technical issues today, again, we will be recording this and we will figure it out as we go, but please be patient. Today, on November 20th, we are heading into Encounter Data and Quality Improvement efforts. This is the data reporting and quality webinar series. If you are supposed to be somewhere else, you're here. I'm Amy Peterson. I'm the chief of the Managed Care Data Support section. Next slide. Today's agenda is QMed, or Quality Measures for Encounter Data. It's an overview and update, and then a discussion about how to identify providers within the Encounter data reporting issues. So identifying providers with Encounter issues. Speakers today are going to be Christine Fessler and Mike Niklas. And supporting team members are Amy Peterson, myself, Alvin Bautista, Abi Geber Selassie, Mei Shaneng, Xiaoyan Ma, and Sujung Kim. And we are all here, so hopefully there's no power outages, but we are happy and content little team here. For general questions, please submit your question to the WebEx chat. And please ensure that your questions are visible to all participants, because our host, the person who's actually hosting, is not monitoring the private chat. And for specific questions, please reach out to the appropriate data mailbox, as will be instructed closer to the end of this presentation. We get through all the slides and then we kind of go over all the pertinent contacts. Next question, next slide. Again, today's webinar is being recorded. We will be posting it with the video and the script and all the presentation materials, and they will be uploaded to our quality webinar series. This will be a live link. All of our series efforts have been posted up to date. We also include some other information like FAQ and glossary and other contact information. Are we having issues with something? Let's see. Unable to see slides. Can we have somebody else share slides? We're going to try something really quick. I'm going to go off. We're going to try to fix it. Give us a moment. Thank you. Okay, so if you cannot see the slides, but you can hear, go ahead and stay on. We will be posting this, and if you send us an email to MCDSS, we will send you the slide presentation before it's posted. Okay. I want to introduce you to Christine Fessler, the Chief of Data Quality and Reporting Unit, and she'll be going over the QMed overview and QMed 2.0 update. Hi, Christine. I can see you fine. Thank you.
Okay, good morning, everyone. Welcome back to it's a further update from the September 2024 webinar topic, where we introduced the QMed 2.0, the QMed refresh. For anyone who wasn't able to watch that webinar, again, Amy Peterson and her team have that great resource, the Data Quality Webinar Series. Those recorded webinars are on that site, as well as the presentation deck. As it's been mentioned, it'll probably take maybe 2 to 3 weeks to get this presentation updated to the webinar site, but it will be there. And apologies again on the technical side. So without further ado, I'll just go ahead and kind of reiterate DHCS, we really want to champion high quality encounter data. We really want to ensure that encounter data meets the definition of fit for use. And why is that? Well, we know there's a positive correlation between data quality and quality of healthcare delivery, something that's very important for all of us, and the Medi-Cal participants. So DHCS does require high quality encounter data in order to best support program and population health oversight and to meet the reporting requirements to CMS. So here we just kind of lay out the sources of encounter data and the life cycle. So here we have obviously the members, the beneficiaries who go, have services at the providers. And then the providers submit those encounters or claims to the managed care plans, who then submit their high quality encounter data to DHCS. As you can see here, encounter data is used in a wide variety of programs and purposes, and also reporting to CMS. So it's, very important for us to have that high quality data. So I actually did want to kick it off a little bit kind of interactive as far as the collaborative goals that we do have on the data quality reporting side is I'm going to pop a question in chat if you all can see that. What are the biggest timeliness challenges or delays on your side in receiving encounter data from providers? So, we're looking at from the date of service, maybe from when there's a rendering service date to when the provider then sends that data to a managed care plan, or just kind of any challenges that we'd love to hear your feedback on. So over the course of the presentation, feel free to just pop that in chat. And this is something useful information that hopefully we'll be able to address as part of the encounter data improvement efforts. All right, so if we could go to the next slide, please. All right, so this is just a resource that is referencing, what are the, as far as the enforcement, the definitions and enforcement standards to ensure the data submitted to DHCS is fit for use. There are several all plan letters there, APLs, the links are embedded in the slides. It's all participants responsible to reading the APLs and keeping up to date on the requirements that are in those all plan letters, as well as the boilerplate contract. Another thing that is important for the data submitters to DHCS to fully understand the X12 transactions and have the implementation guides. Just to note, DHCS and the Data Quality Reporting Unit does not consist of medical billing or coding staff. And our team, Data Quality Reporting Unit, does receive numerous questions on X12 transactions. So, it's just kind of the expectations if you're going to be submitting encounter data to DHCS that managed care plans do have those resources and knowledge sets. Unfortunately, we don't have the resources to be able to answer all of the questions we receive. All right, so if we could go to next slide, please. All right, so the ongoing encounter data quality improvement efforts. So there are a few goals. Some of them we want to highlight here. Obviously, is the goal of the encounter data quality improvement efforts and for the QMed refresh is to be comprehensive and collaborative with our trading partners. In the September survey, we did, in the September webinar, we did send out a Survey Monkey to the managed care plans who are currently receiving a QMed report card. And so as part of the collaborative efforts, we did get that feedback. And so one of the helpful bits of information that our team saw was that the managed care providers are using the QMed report card in part to help educate the providers in the importance of sending high quality encounter data. So that was great to hear. Obviously, another goal that we do have is to reduce the complexity and provide clarity of what the measures are actually measuring. Another takeaway from this survey was the current grading of a QMED is quite complex. I didn't put a picture in here to give everybody kind of, confusion on a early Wednesday morning, but it is quite complex. You have data quality dimensions that are aggregated and then scored categorically in compliance or non-compliance. And then those are further aggregated, and then the end result is kind of a quality GPA. So it is complex, and some of the feedback that we received was it's difficult for the managed care plans to know, what part of the timeliness measure was really the driver? Why did that one underperform? If I underperformed on one of the measures, but I passed the other ones, I still got a non-compliance or underperformance. So definitely taking these into account. And then the other aspect is from the educational side that we did receive from the survey about how managed care plans are using QMED to help educate providers, is that it is a goal to develop, as part of the provider encounter data improvement efforts. We want to be able to connect providers with the technical support to help address some of the persistent encounter data reporting issues that the managed care plans experience, and then DHCS receives kind of those data issues. All right, so next slide, please. All right, so this is just a kind of another high-level overview. What was said in the other slide, we are looking to develop a program that will connect targeted providers with technical vendors to address those data quality encounter issues. We want to improve the coordination and communication with managed care plans to promote the encounter data quality improvement. And then, of course, we're working to update the QMED measures in the report card. So again, QMED stands for Quality Measures for Encounter Data. So if we could go to the next slide, please. All right, so we here's a slide that California is not looking too great. And this is in a data quality element and a demonstration of how CMS is using managed care encounter payments data to score each state on its data quality. So clearly for this measure, California is deemed as having high concern. And so this is a measure of focus for QMED 2.0. We want to cover the high priority TMSIS issues, as well as have measures that incorporate the contract requirements and business needs. We do understand that this is obviously a collaboration between DHCS and the managed care plans. And so we just want to really make sure we can work together to help improve encounter data quality. And, we're all in this together, so I know we can get it done. All right, so next slide, please. Oh, QMED. All right, so next slide. All right, so this is just a refresh of the QMED, the program purpose and background. So it was initially rolled out in 2015 for the federal reporting requirements and the encounter data submitted to DHCS. Another aspect of the survey for the feedback was how long it took DHCS to carve out pharmacy from being included in the QMED scores. Obviously, there's a lot that happened from COVID and whatnot, but we did get that done. And we do recognize, thank you for the patience, as we did get that process completed. And so just another part of the feedback was, as you can see, there's 8 threshold measures. There's also 20 informational measures for monitoring purposes. And so there's just a lot in the current QMED. Some of that we're looking to revamp, obviously, to be comprehensive, but less complex. If we could go to the next slide. All right, so again, this is just kind of reiterating the new focus for QMed, incorporating the TMSIS, high priority. There's also new programs and initiatives such as CalAIM, and then the reporting requirements in those per kind of the changes to the contracts to have managed care plans report on those programs. We could go to the next slide, please. And after this. All right. So, I'm sorry, if we could go back one. Thank you. All right, so here are the QMed 2.0 measure priorities. So again, we want to recalibrate to focus more on more recent data quality issues. We're looking to add 2 new data quality dimensions. Again, focus on payment is going to be one of them we're looking at. For the DHCS business needs, we're also going to be focused on things like uncorrected denied encounters, any sort of duplicate encounters. We're also going to be focusing on some contract related aspects, the language in the contract as far as the definitions of timely submission, and what that means for the providers, managed care plans, and DHCS. And then as far as, kind of the scope overall, like I said, right now, the QMed report card is only being sent out to managed care plans, but we're looking to expand that to PACE organizations, and essentially everybody participating behavioral health, dental as well. And that it would be the longer term goal of QMed 2.0. All right, so if we could go to the next slide, please. And again here, for those of you receiving the QMed report card and have attended some of the prior data quality webinar discussions, you will hear the CART dimensions. And so that's an acronym for completeness, accuracy, reasonableness, and timeliness. For the QMed 2.0, we're looking to add 2 new data quality dimensions, uniqueness and consistency. And again, that applies to things like duplicate encounters and other required reporting data elements like NPI information that is there or not. So we will be adding additional data quality dimensions to encompass the growing data quality measurement needs. All right, if we could go to the next slide, please. All right, so just again to talk about the measure topics of QMed 1.1 or current QMed versus QMed 2.0. Here we're just kind of comparing, contrasting the existing measure topics and then what the new measure topics we're looking to incorporate. I've said this a few times, we're looking at duplicate service lines, paid amounts, and then encounters for the new programs, the enhanced care management and community supports. All right, so if we could go to the next slide. All right, so this one again, grading. Grading is complex. Again, I could have included the very complex overview of the grading, but this is kind of a much better job. So the current grading, as I said, is quite complex. Each plan is assigned an encounter data quality grade, which is an aggregated score based on performance by quality dimension and quarter. So again, we said the CART dimensions, which is completeness. So the completeness quality dimension could consist of 3 measures. And in fact, it does, which means that while each HCP is given a score on completeness, those scores are aggregated. And then you're looking at scoring at the planned parent level. And all of those timeliness or quality dimensions on each quarter is scored and then aggregated to the planned parent level. And then that planned parent level will receive an encounter data grade point average that is based on the underlying plan data quality grades. So the issue with that, and something else that we see from the survey, is the grading is relatively severe in that you could have, say, 15, managed care plan ABC has 15 HCPs, and you could say 13 of the HCPs are compliant on their scores. And if one of the HCPs is not compliant, then the non-compliant is applied to overall. And so, there were reasons for that, but we're looking at, if we go to the next slide, where we want to go, the QMed 2.0 grading approach, we still want it to be, it encompasses what we're seeing for the data quality issues, but we also want it to not only be helpful to DHCS, but to managed care plans in being able to identify the specific measure to what is driving potential data quality issues. The grading is also less severe. For non-compliant, we really need to see a trend in the same measure for a period of time. So we're really wanting to look at a trend before we kind of get into the warning letters or the caps, things like that. So we're trying to provide clear information to managed care plans and to DHCS as well. So we're going to be looking at the threshold measures in current quarters and not like on an aggregated level. So that's going to be a big change, I think, there, hopefully for the better. All right, so if we could go ahead and go to the next slide. Thresholds. All right, so the thresholds. To measure the data quality and scoring, there is a threshold that the plans have that designates whether or not it is compliance or non-compliant, so pass or fail. So we are going to be doing a few changes to the thresholds. The current QMed has 8 threshold measures and 20 that are informational. So for the QMed 2.0 future, we're still going to be incorporating threshold measures that will be used for grading. The report cards will also still include threshold and informational measures. The 2 big changes that we're looking at is we recognize that data quality and data is kind of a living issue. It evolves over time, and that could be, whether or not there are new initiatives that are rolled out, there's new APL language, there might be new guidance from CMS. So we want to be able to have QMed 2.0 have the flexibility to incorporate new data quality concerns and then be able to retire some of the data quality dimensions that are no longer accretive to understanding the data quality issues. So that's a couple of the things that we are looking at. Currently, there's no process to update or retire measures. So that's something that the team will be including as part of QMed 2.0. We could go. Thank you very much. All right, so this will be a phased rollout. As you can imagine, there's a lot of things to test. There's data quality measures to build, business rules to write. So the team is working on adding and testing the new data quality measures in a phased approach. So what you see here is the draft timeline for the QMed 2.0 implementation. So what we are proposing and what we plan on doing is for the QMed 2.0, we will focus on the managed care plans that are currently subject to QMed 1.1. And then other capitated plans, as listed here, will be phased in over time. So what we're looking at for early 2025, probably first quarter, is posting the new QMed 2.0 methodology on a public website. And that it would be an update to the current QMed 2.0 methodology that managed care plans receive in their quarterly email alongside the quarterly report, which describes the data quality dimensions, how the measures are calculated, and how grading is done. And then for Q2 of 2025, we'll be looking to begin sharing the QMed 2.0 report cards with the managed care plans. And then as far as the enforcement clock start, the warning letters, we would look to be potentially 1 year after the first report card is issued. So that would be in 2026. So this is kind of our estimated phased rollout. Obviously, as we'll continue to have these webinar updates on the status of the encounter improvement efforts and any additional details on the measurements. So I guess, are there any questions? I believe that is the next slide. Okay. Yeah, so like I said here, we will be having future discussions for the data reporting and monitoring webinars related to QMed 2.0. So if there are
are
any,
a few questions actually, Christine, in the chat. Unfortunately, my computer's not working to go ahead and read them. Is anybody else open this up and read it in my team?
I do, oh my.
Okay.
I
Can
might not
you
be able to
scroll up and
address,
see 'em?
I do see them. There are quite a few questions. I'm wondering if, should I hand it off to Mike Nicholas? And then we could circle back to the questions in chat, so I have kind of time to read them and.
Yeah, I'm
Okay.
fine with that if you are. This was your slide. So if you wanted to answer questions live, we're happy to take that, or we can wait till the end. And that might be better because we are having some very interesting technical issues with all of the stuff that's going on today. So that would work for me.
All right, thank you.
Thank
And
you.
Christine, I think based on the information and the questions in the chat, I might be able to help assist you at the end of this as I was scanning through some of these.
Thank you, Mike.
So we
Super
might be able to
appreciate it.
work together near the end to try and address some of those questions, or we can take them back, and I think we can then maybe be able to provide some better informed answers if we don't have them off the top of our heads, because some of these questions we might be able to answer, some we might have to take back to be able
That's
to give
right.
proper responses to.
Okay. So I guess just before I hand it off to Mike, we do have a slide here. So the DHCS questions for plans. We'd love to continue hearing feedback on the current QMed report card development and distribution process. Currently the plans are receiving them by email as attachments for PDF reports. So if there's any other preferred distribution or receipt of the report cards, please let us know. And then, again, what sort of format is most helpful for you all to also receive updates and the information related to QMed 2.0. We've got written documentation, webinars, office hours. And then we do have a new email address here, data quality reporting unit. As we've become more formalized for the data quality reporting unit, please send your QMed related topics or questions for QMed 2.0 to this email address. So I guess that's it. Again, Mike and I will do our best to answer the questions at the end, but I think I'll hand it off to Mike Nicholas, amazing superstar in the data quality branch. So thank you, Mike.
Okay. Good morning, everybody. My name is Michael Nicholas. I am the chief of the Data Quality Improvement section inside of Department of Healthcare Services. My team works a lot with the data inside the department, the anomalies, the issues that we identify in a lot of encounter data, as well as in eligibility data. So my team really works hand in hand with our Transform Medicaid Statistical Information System, otherwise known as TMSIS. So my team is very familiar with the data quality issues that reside within the department. So one of the things we wanted to kind of cover is that DHCS knows that we have issues in our encounter data reporting. And we want to help address those issues, and we want to provide more support to the managed care plans to get those and to be able to assist the difficulties they're having with their providers to try and improve that data quality to meet the requirements necessary for reporting. As you all know, that DHS is required to meet federal reporting requirements. TMSIS is a federal reporting requirement that we must do for the entire program, which also includes all our managed care and encounter data. So as we go through this, they hold us to a very high standard on the completeness and accuracy of that data that is submitted, and they're also getting more into the accuracy of that data, not just the completeness and accuracy, but they're also looking more at the reliability of that data, specifically around a lot of the data file validations that they do. We know that the managed care plans are contractually obligated to provide accurate and timely encounter data to us, but it also falls upon us to ensure that we're also relaying the information of our CMS federal reporting down to the plan, so they can make sure that they're getting the proper edits in place and being able to communicate with their providers to be able to get accurate data. This is a effort that we all need to work on and improve to try and get better quality data to the department. And we know that the managed care plans run into challenges. At one point, I used to work on the fee-for-service side of things, so I understand that there are challenges and difficulties at the provider level in getting good, accurate, timely encounter data in, because again, those providers have challenges in and of themselves in their own practices, and we know that there are providers and provider types that can give specific managed care plan challenges, and we want to be able to work with to try and resolve them and try and make the data quality as high quality as we can, because this also really helps us to develop metrics and be able to really show the quality that our members are receiving from all the managed care plans. Next slide. So some of the things we want to consider is DHS is considering opportunities to partner up with the managed care plans and providers that are able to identify that when they're facing persistent encounter data and reporting challenges. We want to be able to give proper guidance and assistance to be able to get to where we need to have high quality data. So in order to this, we are going to rely on the managed care plans to help us identify individual providers or even groups of provider types that you see and having issues with submitting complete and accurate encounter data. So we want to try and identify those providers or those provider types that might need more guidance in order to be able to provide appropriate claims that then comes through as accurate encounter data reporting. The efforts to build this, and we're trying to build on initiatives that already took place. So we know that Integrated Healthcare Association and the California Medical Association has put initiatives forward, but I think we want to then start building, our relationship with the managed player plans to be able to give that appropriate guidance and help answer the questions that I believe that are out there that you are looking to the department to help resolve. So we're trying to then build this communication and build this effort to be able to give you the appropriate guidance you need to be able to implement changes into your system and be able to give guidance to your providers to be able to improve the data quality submissions coming through. So one of the things we wanted to put out there is, what guidance can DHCS provide the managed care plans to help, what guidance can provide, to identify providers experience persistent encounter data reporting challenges. This is an effort between us, and we need to work in collaboration to identify those issues that are persistent and that we can do to help improve the data quality. Because ultimately, it only helps the members to be able to improve the data quality, to be able to tell the appropriate story of how these services are helping improve our members' healthcare. With that, are there any questions about kind of what we're trying to do moving forward in the next few years?
And again, we're collecting questions in the chat, and we
Mike,
can
if you
get
can
some
see
of
the
those
chat.
answers now.
Yeah,
Mike, can you see the chat?
I'm going to try and move it up to see if I can, I can get the chat. It's just kind of small. Let me see if I can move it so I can get a better visual
Yeah,
for it.
it's not
Probably-
working as ideally as we would like, but things are not working as ideally as I would like today.
Okay, let's see. I'm trying to go. Yeah, I do have some
I
visuals
can
in the chat.
read them to you if you'd like.
And I
No.
would say Mike, there is one question that came up while you were speaking.
Mhm.
Paul Lou, does your rollout phase provide accurate time for managed care plans to understand and implement the changes?
Yeah, I think that's one of those things, is trying to come up with appropriate timelines.
Sure.
So we see data quality issues currently in our encounter data, and one of the things that we're trying to work on internally is trying to get an appropriate timeline in which we can communicate the changes necessary to the managed care plans to make edits in their systems, so they can then relay that information to their providers so they can make changes. So everything, I wouldn't say is seamless, but trying to build those appropriate timelines, knowing that there are levels that need to go through to make those changes. So we're trying to be able to set timelines in which we will provide a notification that, hey, we're going to recommend this change. This is when we're working that internally to try and set those parameters to give the managed care plans the appropriate time to make those changes in their systems, as well as communicate out to the providers of changes that they might need to make in their systems in order to align with what DHCS is moving towards.
Right. And that applies really to anything, for example, even changes to the JSON files that some
Correct.
are submitting. We
Mhm.
are working to understand plan timelines when we
Correct.
propose changes to files, how
Mhm.
much time do plans need to update their
Mhm.
systems. We certainly want to give you the time you need.
Yeah, the goal is to be able to make sure that you're able to implement it properly and all the way down the line your providers. And again, we're trying to make sure everybody succeeds. So trying to build those timelines out that meet everybody's expectations. That's a little bit of a challenge, but we're working through trying to identify those.
And I'm just going to throw this in there. Frankly, we could probably do a whole presentation on local codes and everything associated with them.
Let's do it.
Yeah, I'm not going to go down the
Yeah,
local
it's a thorny
code path.
issue. We're aware of it. Yeah, we want to address it, but there's a lot to it. So
Yes, because I do have experiences on both sides. So
yeah.
any other questions we might have that we might be able to address in
We
here?
do. I scrolled up to where the answers to Christine's question ended, and we do have a question. Are the plans supposed to send denied encounters in our submissions?
So I will answer it this way. From a TMSIS perspective, CMS is expecting us to submit denied claims, which we denied encounters as well. We are currently working on internally how to best request that data from managed care plans, because again, we're building the denied claim criteria out on our fee for service side. And so we're working on, what is the appropriate transaction to be able to get that data from the managed care plan. So as we work it out internally, we will eventually start giving that information out to the managed care plans, probably through this webinar on what they can expect in the future. But that is definitely on my list of things to do from a TMSIS perspective moving forward. But yes, since it is a different it's different when we're dealing in a managed care world, that we're going to try and identify the vehicle for the denied claims and the transaction type, so then we can set up the correct exchange to get that information.
Yeah.
So the answer is yes, but not quite yet.
Yeah, yes, and it probably won't be in the same vehicle in which they're submitting their paid encounter data. There will probably be a different exchange setup that is specifically for those denied encounters. But yes, that is on one of my list of things to do, to start collecting those denied claims.
Okay. Another question is, what measure will be used for paid amounts? Eugenia, do you want to expand on that a little bit? And we can come back around to it.
Yeah, so I kind of see where they're going now, because I've seen some of the other comments in here. So yes, there is. So I can maybe answer it this way. From a TMSIS perspective, CMS has put a threshold on, they will refer to it as an inferential warning. What they do is they have an expectation of X amount of percentage of encounters coming through should have a capitation arrangement in which we would get a $0 pay amount. But if we're beyond that threshold, they expect us to look at that data to see if it is accurate. So one of the things we're trying to do is looking at the data coming in through encounters to ensure that the providers and the plans have identified the payment arrangement accurately on the claim. And I think one of the things we are seeing currently is, under that contract type code, there is a place to put a description that is a capitated arrangement. That is occurring, but we are getting a lot of encounters coming through that are being identified as other with $0 paid amounts. So really what we need to do is probably give more guidance to the managed care plans on the expectation of that contract type code, because again, if it's outside of that capitated arrangement, we should be getting a paid amount. And currently we're getting a high volume of contract type codes 9, which is other, with no paid amounts. So that is leading to a lot of questions from CMS, and thus taking a look at, do we have the appropriate edits in place inside of our encounter data? So that kind of ties into what Christine's team is looking at for 0 paid amounts. So we're working on that guidance currently as we speak.
Okay, and this might be a question for Christine. What will be the study period for QMed 2.0 released in quarter 2 of 2025 and quarter 1 2025 submissions? You might have answered that below too.
I would say that for QMed 2.0, it's going to be similar to QMed 2.0 in that looking at 3 months of data. And for QMED 2.0, again, for the phasing, these are our best estimates, barring no significant, technology or data impacts. Just given the size of our internal database, it does take the team a long time to run queries and write business rules. So that has kind of slowed down the process of being able to do the in-depth analytics we would like. But for the Q2 reporting period, when those quarterly reports are received, that should be on beginning the Q2 data. So if it's a Q2 2025 report card, it'll be on the second quarter of encounter data for that year.
Thank you, Christine. We have a question from Ezequiel Casillas. Validating PACE plans are not subject to QMED 1-2. I think that was a clarifying question.
Oh boy. I'm sorry, which one? I'm looking at Medi-Cal billing manual and encounter data specified companion guides when it relates to rendering PA or NP. Oh boy. Is
Yeah,
this
that's
the
a big
Loop
one.
2400?
Mhm.
Jeff, you and I have talked, we talked with the PACES team about this. Oh yes, we did note that the companion guide does need some updates on how to define this. So Jeff, should I
Well,
turn it over to you? And
the one thing I'd say, if you're answering the latest comment question, is that this is an issue that the providers refer. Well, I should say the main body of information available to providers are the Medi-Cal billing manual, which is oriented towards fee-for-service claim submissions, and our fee-for-service system, which is one of the oldest systems that we have in Medi-Cal at this time. We are making plans and working to create a body of managed care provider data specifications that will be different from what's shown in the billing manual currently. And we realize that does create some issues for our plan partners when the providers are coming to them and referencing the Medi-Cal billing manual. So we have some work to do to get that straightened out. We are aware that the current situation sort of perpetuates many of those issues. It's a question of just getting that material developed, posted, and shared. And we've started in the last few months with some guidance documents that we'll be releasing soon for specific types of encounter data coding, and we have more to come.
And Jeff,
Right, the best I can say right now. Sorry, go ahead, Amy.
I was just going to say, when you are ready to release, we can send that documentation notification out via our listserv. Please feel free to use us.
Okay.
And then everybody who's on this list right now who's subscribed will get notified.
And I think, Jeff, in looking at that statement, and I think in some of these questions coming through, I will say that it's also noted that some of the instruction in our fee-for-service provider manual might not also align to the standard, and we've been working on trying to get some of those items updated as well. So again, looking to the fee-for-service provider manual as guidance on claim submissions might not be the most accurate thing to do, because again, there is some limitations on that system, which requires things to be done differently than you would in a submission on an encounter through PACES.
Yeah, and certainly making some types of changes in a large organization is a bit of a complex and ongoing thing to do.
The one thing is, these questions come through, I think we can see some of these things we are aware of, and we are trying to work on addressing them and dealing with these issues. I
Right.
mean, I see some questions rolling around institutional claims and type of bill and discharge dates, and in what we've seen in analyzing the data, I think Jeff is accurate. Updates to our companion guides will help improve the guidance I think that the managed care plans need to be able to set their systems to adjudicate appropriately.
Mm-hmm. Yes. So
There's a lot of really interesting questions here. We're going to collect all of the questions, and we are going to publish them as FAQs if they are pertinent to managed care plans as a whole. And if they're specific to your managed care plan, we'll make sure that a subject matter expert gets back to you via email, and we will contact you through the MCDSS support email and get you hooked up to the right subject matter expert. But we will probably have to ask you a few more questions related to your question. So I don't want to cut us short. I do want to see if there's any other really hot topics that we would need to hit right now. And I'm relying on Jeff and Mike and Christine to kind of go through
Yeah.
and see things that they want to really hit right now.
Yeah.
I see a couple of questions and I would like to see expanded on to maybe help be able to provide their answer to you. I think one of the questions, do you monitor each provider linked to certain provider types? If you could kind of expand on that question from a little bit of a background standpoint, I think I might know where you're going, but I just need a little bit more information around the question in of itself. I think that was from Oleg.
Yeah, and if I may, we do have a participant, Stephen Lefebvre, who would like to be unmuted so he can speak. He's an Encounter Data.
Can you unmute, please? Can you unmute
Got
Stephen?
a fair amount of expertise to share.
You just did.
Stephen, you should be on.
Yes, hello. Thank you very much.
Yes.
Many of you know me, Stephen Lefebvre, and there's a question on here that I want to answer for Greg White. Greg and I have worked very closely for a long time, Greg White with LA Care, and he asked a question about uncorrected denied encounters. Many encounters cannot be connected. If they are, and he put MEB, I'm not sure what that means, eligibility or duplicates, nothing to correct. So, QMed 1.1 right now allows on turnaround time for correcting denied encounters. It allows a 5% kind of like a 5% cutoff, so that there are certain types of encounters that cannot be corrected, and those being denied replacements, denied voids, and incorrect frequency type code. So those three, and it's a small number usually, but for some plans, a small percentage, I should say, but for some plans, for example, like LA Care, it could be a large number. So for QMed 2.0, what we're going to look at, Greg, is we're going to look at screening out those and not counting them in the measure. So we're going to screen out uncorrectable. Our plan is to screen out uncorrectable denied encounters so that they don't even get factored in, so that whatever percentage of uncorrected denied encounters doesn't include those encounters that cannot be corrected. We don't want to hamstring you for something you can't do. So that's an answer to that question. So that's all I had to contribute at the moment. Thank you.
Thank you, Stephen.
Thanks, Stephen. I think Oleg's question did have some expansion. He had asked earlier about 10 different types. And then let's see. a single provider can have well over 10 different provider types, and do you distinguish those cases, for example? So
Yeah,
you
the
monitor
expand.
each provider.
Yeah, so it'd be because I'm thinking, yeah, because each provider type as it comes through an encounter is usually submitting a taxonomy code. So we'd be able to identify the provider and the service they do by their taxonomy submitted through the encounter.
And then let's see. Can a user guide FAQ be made for local codes, state and federal? I'm guessing.
Where
I
is this?
think, well, I have heard that's that there is an FAQ that is desired to be worked on for some of the frequently asked questions about local
Sure.
code conversions. Sorry, Jeff,
Yeah.
I'll let you jump in.
No, you're right on track. Keep going.
Um,
Yeah, go ahead.
but yes, so I also put in chat, you know, the goal of the data quality reporting unit and also the encounter data improvement efforts. We're also, from a technology side, trying to put together a lot of the questions that are asked in these webinars, and then also those that come in through the mailboxes, like MMCD encounter data or MCQMD provider data. Both of those mailboxes go to myself and a team of 3 people, which Stephen Lefebvre is one of them, Constantin, and then Lisa. They're amazing, but it's 3 people. So we are working to provide frequently asked questions and, you know, kind of by file type, whether that's 274 encounter data. And then we do get a lot of questions on codes. And it's definitely something that will take a bit of time. We just don't have quite the, I'll say, supply of
Resources.
expertise. We do have expertise, but not the amount that's needed, unfortunately, to be able to answer the various questions that do come in. So yes, short answer, maybe in a year, we'll have something to share. And yeah, it is in the works. Thank you for your patience. I'll turn it over to Jeff or Mike.
Well, Mike, do you have anything else? I think at this moment.
I think any of those questions around local codes and FAQs, we'll take back and look at internally, and see based on all the questions around it what we can look at it and what we can look at and do. That the local codes is a rather complex kind of situation. I mean, having worked on those as well. So yeah, we can take that back and take a look at all those questions and see how we can respond to the inquiries coming through in the chat.
Yeah, I agree. And as I've been mentioning, we are aware of the need to create and publish updated documentation that's pertinent to managed care. You are working diligently to do that as quickly as possible and get that out there. We understand local codes. I think ideally we'd like them just to go away, but that's going to be a while. And improved documentation and guidance is one step, one aspect of what we can do to start addressing some of these situations. That's why I've been mentioning that quite a bit.
Thank you. We have time for a few more questions. Can submitters that don't want to share paid amounts, can we require it? Go ahead, Christine.
I actually have another question for the plans and participants. So, and I know this idea comes from Stephen Lefebvre as well, but he's wonderful. And he has mentioned in the past that sometimes Our team is very small, and we don't quite have the expertise. Stephen has amazing expertise, 25 years, but again, we don't get training in billing or codes. So I will put it out there if there's ever a webinar or an office hour, if a managed care plan would like to connect with the data quality reporting unit, myself and Stephen, Constantine, on whether or not you would like to work with us to kind of maybe do a teach-in for putting together encounter data files, some of the issues that you see, how you've worked around them, it's to have kind of a collaboration across, plans. So it's an idea to put out there as well, to have further collaboration and idea sharing. So I'll leave it at that.
Thank you so much, Christine. I like that idea a lot. Should we go back to the last little bit of the webinar information? And did you want to go over some of those contact slides and resource slides? Let me go back.
Sure. For here?
This one is a very common one, and these particular email boxes, live links on the online, go ahead and mark urgent when you do send them an inquiry to Data Exchange or Data Quality Reporting Unit. And you can, if you don't know which one you need, you can always contact us. The webinar support team will get it to them. But no, the next two slides are really all about you and some of the supporting documents and PACES information that you might want to go over and who to contact.
Oh, sure. So supporting documentation, Jeff Jennings and his team, data exchange at DHCS.ca.gov. He is a key asset, does so much for DHCS and trade partners, our trading partners. His team has put up the DHCS Doc Center on Microsoft Teams, which has been so helpful. And on the DHCS Documentation Center, you'll be able to find the PACES custom error messages. Again, that's something that all plans should download, be familiar with when you ask questions, and our team receives them and the answers in the companion guide. Well, we usually say, please look at the companion guide. So obviously there's some companion guide information that does need to be updated, but we do have the institutional, professional, dental, and then the NC PDP 2.2 and 4.2. If you do need access to the DHCS Documentation Center, you can email Data Exchange, and they will be able to quickly give you access. So please, please, please download the documents and review them. And let's say, I will say another thing, it relates to the slide. When you do send an email for the subject line, it is helpful to put in urgent, but then it is also very helpful for routing that the subject line is specific to, like, is it an 837I, 837P? And then if you're having issues with a specific file, please put the file name in the email. When we do create the PACES tickets for the PACES team to look up, it's very helpful for them to have a file name to look up. If that's not included in the email, it just creates kind of extra back and forth trying to get those details. So please provide as much detail as you can. We recognize that, a lot of you do a very wonderful job, and we appreciate the patience again. Again, we have 3 people answering all these questions, and so we appreciate the collaboration and patience.
We definitely appreciate you guys too. Thank you so much to all of our panelists who came on today and spoke. It is a very rainy day today. I know we have a lot of participants who probably didn't make it due to the rain, and we really appreciate it. So the next webinar is coming up in December. It's going to come a little early, and we will be focusing on PCPA data updates, and we'll be doing a year in review and kind of revisiting some of the information that has been shared, as well as what some of the EDM department or divisions are doing with the data that's being submitted. And that meeting will be happening on December 11th. So it's a real quick turnaround, but we want to give you Thanksgiving and we want to give you Christmas. Please note that any topics in the future may also change on our webinar page as things become more urgent or questions trigger a new topic highlight. And we will notify you if there are any changes occurring. You can also go to the webinar page and subscribe or unsubscribe if this is not your thing anymore, or you do want to subscribe and you want to come to these particular meetings and be invited, continue to be notified when they happen. But again, all of this information is up on the web. We will be posting the actual presentation and the slides, and then the FAQs and any glossary terms that are new. So hopefully that gives you a lot of opportunity to have some really robust information shared by DHCS, and we will continue to try to provide better and better possibilities for you to understand what we need from you. Thank you so much. I'll leave the webinar up. And if there's any further questions, you may put them in the comments, but we'll stop recording. Thank you so much, everyone. Take care and happy Thanksgiving.
Thank you all.